Welcome back to A Cup of Joe. Today I'm joined by Christy Boerger, who is the Director of Pulmonary and Cardiology for Oak Bend Medical Center. She has been a respiratory therapist for 22 years and all of that time with Oak Bend Medical Center. Truly honored to have you back again. And we're going to have a great conversation. It's so, I'm not sure if the weather is ever going to turn cold, but when it does turn cold, people need to know what's going to happen to their lungs.
Hey, we've had a few cold spells here.
We did.
Right.
And then we're going to go into the 80s.
I know.
It's a crazy place that we live in nowadays, but it keeps us busy. So my first question is, what does pulmonary mean, and what kinds of breathing or lung problems does it include?
Sure. So pulmonary is lungs. So anything that pertains to your lungs, breathing. So you think of your asthmatics, you think of your COPDs, you have lung cancer, you have pulmonary fibrosis.
Oh, I want pulmonary fibrosis.
Stiffening of your lungs.
Okay, good. Thank you. Got to translate it into layman's language for me. Thank you.
Yes. So anything that can affect your lungs, we deal with. Okay. And that's what we do.
Okay. And which of these conditions tends to worsen in the winter months?
Oh, gosh. Really all of the above. Because you have COPD. So their lungs are already strict.
COPD is
chronic obstructive pulmonary disease.
Okay.
So with that, our lungs are like this.
Okay.
Nice, big, round, we can breathe. When you have COPD, that airway is now smaller.
Okay.
And when you have cold air, that then constricts it even further. And so now their airway is really small. And then when you have asthma, that then tends to cause these bronchospasms.
Okay, wait, we're combining two. COPD, I presume that's a disease that is typically a byproduct of smoking for an extended period of time?
Yes.
Okay. So I'm an ex-smoker, or I'm a current smoker. My lungs start to contract because of the smoking over the course of time. And then in the winter, the cold air causes them to contract even more.
Further, right.
So that makes it harder for me to breathe.
It is. It's almost like a suffocation, and that's how you feel.
Oh, wow. I don't want that.
I know. It's a horrible feeling. You have the anxiety that comes with that. Like, I can't breathe.
Oh,
you start breathing harder, faster, dizzy, feel like you're going to pass out.
That's not good.
And then you come to our ER, our wonderful no-wait ER, and we're here to treat you.
Oh, I love it. Okay. So there's a treatment, at least temporarily, to get me over the crisis.
That's right.
And then you were starting to talk about asthma. So if you have both COPD and asthma, then you get bronchial spasms.
So now your airway is doing this, right? And so
that doesn't look good.
No.
My airway is supposed to stay open like this.
It's supposed to stay open. So then we give you medication to help with those spasms.
Okay.
So that you can breathe. And so when you do that, of course, coming to our ER, we help treat those kind of issues.
So people don't get treatment for this at home? They don't...
You can. I mean, you have oxygen that you can have at home. Okay. You can do breathing treatments at home. You have inhalers that are at home. But there comes a time where those are no longer effective. And so then you come into the ER. This is where you get that fast treatment of albuterol. Maybe some of you have heard that.
Okay.
And that helps to relax your muscles that line your lungs. And so once that's relaxed, you can breathe again. Sometimes that takes several treatments. And so we say ER because we have to watch for your heart rate. We have to watch out, making sure that doesn't increase. The albuterol tends to give you tremors. And so we want to watch you for a period of time too, to make sure you do recover properly. If that doesn't work, then sometimes we have to give you steroids.
Okay.
And once we do the steroids, that helps with that inflammation. And so it helps to open you back up too.
So coming back to albuterol, I seem to recall when I had some lung issues myself that I got albuterol for my nebulizer. That's normal? That is normal. So what's the difference between the albuterol I was taking at home and the albuterol that I would get here?
There's no difference.
Okay.
It's the same strength. We can just give you back-to-back treatments, watching your heart rate. You don't want to do that at home because you need to be monitored.
I got it.
And so that's why we want you to come in so that we make sure that you're safe.
And you can't go into your physician's office because they don't have the monitoring.
Right. So they usually give you a treatment and then they'll send you our way and we're here to treat you.
And I presume urgent care, they don't have monitoring.
They do the same. Either. They do the same too. One treatment. Send you to the ER. Listen to your lungs. You'll hear the wheezing, and the wheezing sound is that really narrow airway.
Gotcha.
And then that's when they'll push you to come,
Okay.
to the nearest facility.
So you named several things, COPD being one of them.
I think that's our biggest respiratory illness
Okay.
or condition is COPD.
Now, is asthma also affected by the cold weather?
It is. And
Okay.
so just the same, like with COPD, that also constricts your airway too.
Okay.
Just that cold rush of cold air.
Okay.
And even when me or you walk outside, we kind of, ooh, it's cold, it's that cold air hits you.
Yep.
When you already have these lung conditions, that cold air really does then constrict your airway.
Okay.
So when you already have these conditions where your airway is already smaller, that cold air hits, now your airway is even smaller. And so cold weather is not a nice friend to my friends of the respiratory world.
Okay. So, keeps you guys busy.
It does.
Okay. Well, good.
Yeah.
Thank you. That makes a lot of sense. I really didn't fully understand although that interconnection between the cold weather and lung performance. So, okay. So, Christy, what's something that surprises people about how their lungs respond to cold weather?
I think our body does a lot of work that we don't seem to realize it. And I think one of the things with cold air, our body does this rush of blood to our nose. Oh, so let me back it up. I'm sorry. Cold air dries our nose. This is, the germs are like, hello, I'm entering your body.
Wait. Why does cold air dry? Do we have lower humidity?
Right. So when you have cold weather, dry humidity.
Okay.
It's just this passageway for germs to say,
okay, so the moisture in our nasal passages helps to filter the air of the germs that are naturally part of the air. But when it dries out, then that's like an open pathway for the germs to come into our bodies. Yeah. Okay.
And they're ready.
Okay.
They're ready for this weather.
Okay.
As you can see. I mean, we've got flu A going crazy right now. But the thing to surprise our bodies, the blood flow goes straight to your blood vessels in your nose, which then provides this increased moisture. And so then we have these runny nose, but it's to protect your airway. And so then to like say, hey, germs do not enter.
Okay.
And so we have this runny nose. And that's just because your body is trying to protect itself.
Interesting.
So
that's why kids have runny noses all the time?
Oh, gosh. Well, who knows? Who knows what they've picked up along the way.
But there's something they're fighting,
I know,
which is triggering the runny nose. Okay.
Right. Yeah.
Interesting. So are there certain groups of people that tend to be more susceptible to these pulmonary issues in cold weather periods?
I mean, you're elderly, those that have the comorbidities, meaning you have more than one type of disease process going on. Of course, anybody with lung issues, the COPD, the asthma that we've already talked about. Children with RSV, which is a nice respiratory illness with these littles. Okay. So nobody is free from getting sick, but those that have immune compromises already are those that are going to get hit a little bit harder.
So the elderly, the young, those who have conditions that make them susceptible, like asthma, like COPD, blah, blah, blah.
Yeah.
Now, your lungs, it seems to me when your lungs are kind of constricted in one way or another, that puts stress on the rest of the body in some way or another. Does that cause your heart rate to go up, your blood pressure to go up?
All the things, right. And so a lot of times when you have, let's just say, the flu, and that has hit your body, you're usually sick for like a week.
Right.
And during that week, you're going to have you could possibly have secondary conditions that lead to pneumonia.
Right. Right.
And so then that
comes when I'm lying around in bed all the time.
Right, because you don't feel good.
The fluid settles in my lungs.
Yep, and you don't feel good, right? And so then with these illnesses, then you'll have the increased heart rate, you'll have the blood pressure, you'll have the shortness of breath, you'll have the dizziness.
So I'm like compounding things. I started off with a simple case of asthma or COPD. Not that it's simple if you have either of those, but we started off, or whomever the person is that has this condition starts off with it, and then gets added on top of it that they're getting other issues. They're getting increased blood pressure, increased heart rate. So it's a compounding effect.
It is.
Wow.
And that's why you feel so bad.
That's why our hospitals fill up in the winter months.
Yes. This is our busy season. This is our season.
Yeah.
unfortunately.
Okay. Well, very good. That seems to make a lot of sense to me.
Yeah.
Thank you.
Yeah.
Okay, Christy. So we're in a typical patient room here
Yes.
at Open Medical Center, and you brought with you various different devices to help people breathe. So if you could go through, I think there is at least 4 of them that I know of.
Sure.
If you could go through what each of them does and what it's used for, you
Sure.
know, and also if you could help us understand which ones of them are available in a hospital versus a freestanding ER versus an urgent care / physician office.
Sure. Let's go
So
over it.
let's start off with the lowest acuity,
Yep,
or
let's
the
do it.
least invasive,
Sure.
and we'll
So
move up from there.
I'm going to scoot this over towards
Okay,
you.
beautiful.
So our first device that we have here is a nasal cannula.
Okay.
So this device will connect to oxygen, and we
Okay.
can run this anywhere from 2 to 6 liters.
Okay.
So this is going to flush oxygen within your system,
Okay.
help you breathe almost instantly. It feels better to have that air, especially when you're already short of breath. Just having that air go in is just relief. You can find this in your urgent care, your standalone ERs.
I see people walking around with like little pouches with a small canister in it. Is that what they're doing?
That's right. So those are my COPD friends.
Okay.
Or anybody who requires that extra hit of oxygen, I guess you could say. So this is our basic cannula, and this is what we start our patients off here.
Okay.
You continue to go downhill. We are looking at your heart rate. We're looking at your oxygen level. We want your oxygen level to be above 92%.
Okay.
So once that starts dropping, we start thinking, okay, what else can we do? And so our next device that we have usually is we put you on what's called a non-rebreather. So some of y'all may have seen this in television shows. This is your bag. It's usually full of oxygen. This gives you 100% oxygen.
So that doesn't give me 100% because
this does not give you 100%.
Because I'm breathing in air around it.
That's right.
So I'm mixing the oxygen
with air.
Okay.
That's right. So this non-rebreather is just 100% oxygen.
Okay.
Yep. No air entrainment.
Okay.
And so this is our next device that we'll put somebody on.
Why is it called a non-rebreather? That's always kind of confused
I don't know.
Oh, okay.
I don't know why it's called a non-rebreather. I guess
because it seems like I'm rebreathing.
Right. You're rebreathing the oxygen that's left in this bag. So we just make sure that this is always filled.
Okay.
And so making sure that you have the air supplies a lot of times.
Okay.
We come in, we can almost immediately tell if you're going to need this or not, just by your symptoms that you're coming in, huffing and puffing. We connect you to a monitor. We see that your oxygen's low. We're going to put you on this.
Okay.
And help catch your breath.
And this is available in a physician's office?
It is. I don't know about a physician's office.
How about urgent care?
Urgent care, yes.
Okay.
This is what we see a lot of patients come in with.
Okay. So you can connect that up to normal oxygen tank.
Yes.
Just like you did with your nasal
cannula. Yep.
Okay.
You're still having a hard time breathing.
Okay.
Our next step is then to put you on this machine, which is called a BiPAP machine.
Okay.
So this is one step before life support, which is really scary. And we don't want anybody to go through that.
Okay.
So we are going to stop that from happening. And hopefully this machine does the trick for you.
Okay.
And so this machine is only available in a hospital setting.
Okay.
You won't find this in an urgent care or
how about a freestanding ER?
I don't think they would have them in the freestanding ER either.
So before you turn it on, because I know it makes a lot of noise, tell us a little bit about how it's working, what it's connected to, and what all this gadgetry is doing.
So it connects to oxygen.
Okay. Which would be present in a freestanding ER.
It will.
But they may not have this machine because it's not a cheap machine.
That's right.
Okay.
So this machine helps blow in air.
Okay. So in everything so far, it's my own lungs pulling the air in. This is actually pushing the air into my lungs.
It is pushing the air in. Yep.
Okay.
And so we set some inspiratory settings. We'll set some expiratory settings.
Inspiratory.
Breathe in.
Okay.
And you breathe out.
Okay.
And so this helps to keep your lungs nice and open during this process. It is almost an instant relief, especially to our COPD patients. And even our asthmatics when they get so tired because of the constriction.
Gotcha.
And so we put this on, and it is almost like I can finally breathe.
Okay.
Unfortunately, it is a big mask, a big scary mask that we have to put on patients. It covers your nose and your mouth.
Okay.
Because we want all this air to go in, all the
Okay.
oxygen to go into your lungs. And so this does look scary, but for my friends out there who have to have this, they understand and usually will ask for it.
Okay.
And they're like, I just need the BiPAP machine. I'm like,
Okay.
I've got you ready. And so we'll connect this to the patient. We'll turn the machine on.
Okay.
For this instance presentation here, I have our nice test lung here. So I'm going to turn the machine on for a second. It's going to do a self-alarm. It's going to be a little noisy here for a second. But I'm going to show you, this is your lungs. So I'm going to show you what this looks like.
So this is not normally part of the device. This is just for demonstration.
This is your lungs.
Okay, that's simulating my lungs.
That is simulating, right. So you can see how the air goes in, opens you up, and you can see it leaves a little pressure in your lungs. So normally, you know, your lungs would be like this. So it keeps a little bit of air in your lungs as well while you breathe. So it breathes with you. So we have a setting here. It's a spontaneous mode. So anytime you breathe, it breathes with you. So you just get like a bigger puff.
You trigger it by your intake. Inhaling.
Yep.
And then.
So we need you alert enough to be able to function your own.
Can I sleep with that?
Well, there's a CPAP machine.
Okay.
So you can sleep with this, and usually our patients that do come in have to wear this up to an hour, sometimes longer, overnight, maybe even a day, just to help recover, help get the medication in your lungs, help open you back up. But
so BiPAP and CPAP.
So CPAP is just a continuous pressure for night.
Okay.
So that keeps your airway open. So that's your sleep obstructive, like
so
your sleep apnea.
We have that here too.
We have this here too.
And that's something people have at home, though.
That's right.
That's very common for people to have CPAP machines.
And the machine that we have here is this machine for our CPAP too. And so you see the mask that we have. So for people at home, they go in for a sleep study. They get fitted to a nose piece that's more comfortable than this mask that we have. They prefer to use their own machine because it's set to what their settings are. So you go through this whole process of sleep apnea study where they watch you sleep. They see where your oxygen level drops. They'll add some oxygen to you to see kind of what maintains your airway to stay open. So somewhere during your night, your REM sleep, your muscles relax so much that it kind of shuts your airway. And so then you're not really getting in the air that you need. And so this machine, CPAP machine at night, then keeps that open continuously for you.
So this BiPAP would function as a CPAP machine?
It can.
In the hospital?
It can, yes.
We don't have separate CPAP machines?
No, this is it. This is an all-in-one.
Okay, all right.
And a lot of facilities have this too.
Okay.
Hospitals. We just ask you to bring in your own CPAP because it's set to what you normally would. Right. You don't like to sleep with this big thing. Nobody wants this on.
Right.
They want what's comfortable for them. You want to have a good sleep too.
Right.
You're in an awkward setting. You're not comfortable, right? So we're trying to help you as much as we can during this process of your illness.
Okay. All right.
Yeah.
And then if this doesn't work,
oh gosh,
then where do we go?
Then that's the very scary life support. Okay. Where we have an airway tube that goes in to help you breathe. And so this happens when your condition worsens. So let's just use flu as an example, like we've been talking about. When flu then becomes pneumonia because you're coughing, your cough becomes really junky. That mucus is thick and sticky, sticks to your lungs. Now you're not coughing it out. Now it's just sitting there, just
clogging things up.
Yep. And so with that, you get pneumonia, and you start having fever. Your cough, you can just tell that your cough is really junky and it's not coming up. You can feel it in your chest. Your chest is junky. So unfortunately, the next step is then to intubate. It's scary for a lot of people. It's scary for anybody that has to be in that circumstance. But it's only for a few days, and that's going to help us keep your airway open, going to relax you. You're going to be sleeping the whole time. We use sedation to keep you nice and sleepy. But this is a great way for us to, unfortunately, suck out all the nasty mucus that has built up, make sure you're nice, clean, clear, so that we can get you off of that ventilator as soon as possible. Okay. And so we don't ever want it to get to that point. So we try to do as much as we can.
You're breathing for me with the ventilator.
I am. Yep. Okay. So we have you nice and comfortable.
Not for me, for the person.
That's right. Yeah. But yes, you're right. We don't want you to struggle.
Okay. Okay.
And so we will make you comfortable.
Okay.
And
most people, I mean, I guess everybody is sedated when they're intubated.
That's right.
Okay.
Yep. And so there's a weaning process too. So
Okay.
once that happens, you're on the ventilator 1 or 2 days. You shouldn't be on the ventilator long term. This is just a quick in and out. Hopefully your pneumonia is well enough that we can take you off. We'll start waking you up. So that sedation is slowly being lifted. Gotcha. Until you can respond to me. Can you raise your hand? Raise your head up. I want to hear you cough. Even though you have a tube in, I want to hear you cough. I want to make sure that it's a strong cough. Because I want you to be able to cough any mucus up. I don't want it to sit in your lungs any longer. Right. You don't want to have that tube back in again. Right. So I'm going to make sure that we can safely pull it. Okay. And so...
sounds terribly uncomfortable.
It is. Okay. And it's unfortunate that some people get to that point that they need that, but we're here to help them. And of course, that's only here in a hospital that you can.
So we can use a BiPAP machine on a regular floor, a medical surgical floor, like where we are right now.
Yeah.
But a ventilator, we only use that
only in
ICU. Okay.
ICU.
Good.
Yes.
Okay. All right. Well, thank you for that explanation.
Absolutely.
That's been very informative.
I know, and I hope it helps all you out there too that have questions about what we do, how we do things, and I hope this has answered any questions that you may have had.
Beautiful.
Yes.
Okay, Christy, if I'm a typical male, which I probably am, and I'm suffering from difficulty of breathing,
yes.
What should I be looking for to tell me if I need to go into the hospital?
Hey, this is too long. So one of the, I guess the easiest thing, you need to know your baseline, right? You need to know what you can and can't do normally. So getting up from the couch to the bathroom, no problem. Getting up to the couch, the kitchen, no problem. Walking around, no problem. When you get to a point where you can't get up from the couch to the bathroom, normally your baseline, you're starting to have shortness of breath, that should start to concern you. Like, why can't I walk to the bathroom without getting short of breath? Why do I have to stop and catch my breath? Why can't I go grocery shopping normally, right? You get short of breath walking around pushing the basket. You're like, this isn't normal. This isn't my baseline. That's when you should go in. Okay,
so if a person has COPD, they're dealing with this on a regular basis.
Right.
I presume that person would normally go first to the nasal cannula and see if a hit of oxygen helps to improve them, right?
Right, but you have to have that. That's a prescribed. It's like a medication. It's prescribed to you, right? So you don't have that at home. Some do, some don't. So if you don't have it at home, they have an oxygen saturation monitor that you can look.
I've got those at home.
Right. So you can buy those at any store, right?
CVS, Walgreens.
Right.
Pop it on your finger.
It lets you know what your oxygen level is. That's a great tool to have. Everybody should have that within their home.
Healthy.
Even if you're healthy.
Because you never know when you might get the flu and it develop into pneumonia.
Right.
Because we're all susceptible to that, no matter what our ages and our underlying health issues are.
Yeah. So it's great to have, right? So then for those that have COPD, they know their baseline. They know that this is what I can and can't do. And when they're just sitting there short of breath, that's a clue. Like something's going on. They check their oxygen level. It's running low.
So if they have oxygen at home, they're going to go to their oxygen.
They are.
And then what's the indicator that that's not working?
Shortness of breath.
Shortness of breath is not resolving itself.
Right.
Okay. Now, a breathing treatment, I might try that also.
Sure. If you have that at home, try a breathing treatment.
Okay.
That's going to help relieve that. When we talked earlier about how constricted you are, that breathing treatment is going to help open you up. Hey, let's see if that works, right? Okay. So if you have that, you'll take and if you have an inhaler, you can use your inhaler. If you have the nebulizer machine, you'll do your nebulizer treatment. Okay, that's not working. Then that's when you call for help. Okay. And either it's to the point where, can I get myself to a doctor? Can you go to your PCP? When do they have availability? If they don't have availability.
Even in this, what sounds like an urgent, if not emergent situation, you're still saying I should call my PCP?
No, I mean, I guess depending on how short of breath you are, really determines what route you take. Okay. If you think, and it's really hard to say because people wait too long. And
That's
then they
what I'm worried about. Is I don't want to wait too long.
Yep, you don't want to wait too long.
What happens if I wait too long, by the way?
Then you're on this machine.
I don't want to be on that machine. So
or
don't
you're
wait
on
too
the
long.
right, and then you're on a ventilator, and we don't want that either
Okay,
because that's
okay.
scary.
Because as it goes on, the condition worsens.
Absolutely. And so we
Okay.
want you to be seen sooner rather
Okay.
than later. And it's
Okay.
really bottom line, knowing your baseline,
Right.
what you can and can't tolerate. You'll know for yourself, like, I've got to get to an ER, like, this isn't right.
Now, in urgent care, as we talked about, an urgent care is not going to be the right setting for that.
Right.
So a freestanding ER, maybe they may or may not have this machine. Can't be assured.
Right.
But every hospital is going to have this machine.
That's right.
So you show up in that ER, and even if you only need an outpatient, meaning you come in, you get this treatment, you go home, because this is not exclusively for patients that are hospitalized.
That's
correct?
right.
It could be down in the emergency department. It could be on the floor in a bed.
That's right.
Okay. All right.
And so we're here to help you, right? So
Okay.
Our sweet smile,
Okay.
our warm hands, we're here to comfort you, make sure that we get you back on your feet and home. So yes,
Okay.
It could be quick. It could be a quick visit. It could be a couple of days.
Okay. Now, are there any other indicators besides my shortness of breath and, compared to my baseline? I mean, heart rate, blood pressure, anything else that would be an indicator?
And I think your cough too.
Approaching. Go ahead, tell us about the cough.
So I think, like you mentioned, your heart rate's increased. You're going to feel because you're working harder.
Right.
And so you're going to feel an increased heart rate. You're going to feel like your blood pressure is rising because you can't breathe. When you can't breathe, you're anxious. Anxious raises your blood pressure, raises your heart rate. So you're going to go through all those things. But also, along with all of that is a cough. And if you have a dry cough, or do you have a junky cough? And if you have a junky cough, if that cough...
You use that word a lot. Junky.
Junky.
So
nasty.
I've never
It's
heard
gross.
that word. It's gross.
It's a gross...
I call it productive cough.
Yes.
You're actually coughing up something. That's
Yes.
your term for
Junky.
junky. Okay. All right.
It's a junky cough.
I like productive much better than junky.
I think so. It sounds nice, doesn't it?
Yeah, it does.
Yeah. That's our respiratory language.
Okay. All right. So if you got a junky cough, it's a good thing or a bad thing?
It's bad. It's bad.
It means you're okay.
You're have an infection.
Okay. And if you have a dry cough,
well, that's just an irritating, maybe it's a nasal drip.
Okay.
That's irritating your airway. It hasn't really produced anything. So yeah, you're going to have these dry, irritating cough. That's manageable at home, cough medicine. But when you start producing junky, all that stuff starting to come up, the yellow, the green, that's your concern. Like, you need to get to a hospital. Okay.
So I'm having shortness of breath, elevated blood pressure, elevated heart rate. At some point there, I'm going to want to get into the ER. If I can't reach my PCP, who may or may not be able to guide me at that point, I need to get myself in or call 911 to take me in.
That's right.
Got it.
Yep.
Okay. Well, good. Thank you.
Absolutely.
This has also been very helpful. So, Christy, let's dive into some waters that have been a little bit uncomfortable of late. So we have various vaccines that are out there. We have a vaccine for the flu. We have a vaccine for COVID. We have a vaccine for pneumonia.
Yes.
How important, how valuable are these? And let's break it down into an average healthy human being versus somebody that's got one of these underlying lung conditions like COPD, asthma, et cetera, et cetera. Tell us a little bit about this in as apolitical a way as we can, because we're not here advocating other than for a person's health.
That's really it. We want you to be healthy.
Okay.
And so one of the things that we like to recommend is to get the vaccine. So we'll just talk about flu since we've kind of been on this subject for a little bit. So you want to get the flu vaccine.
So as a professional respiratory therapist, independent of your opinion as to whether a particular flu vaccine works or not, you generally recommend to your friends and family, get the flu vaccine. It's better than not having it.
That's right. And why?
Okay.
Why is it better?
Okay, tell us that.
So that it doesn't hit you as hard,
okay.
right? So
even it reduces the seriousness of how bad I feel.
Right. So you still may get flu.
Right.
It's just not going to hit you as hard as somebody that didn't take the vaccine.
Oh.
So you may feel bad 3-5 days.
Okay.
You got somebody who didn't vaccinate who is going to feel 10 times worse. They're going to have the soreness, the muscle aches, the body aches that you get.
They're just going to get it worse than me.
That's it. And so I think for anybody out there, you want to have the lesser feeling than having the full-blown feeling. And so I'd rather somebody take that step to be vaccinated, may or may not wish to do so. But it's something I think that you should be aware of.
Okay. Do you feel the same way about the COVID vaccine and the pneumonia vaccine?
For sure pneumonia as well. I don't think so much for the younger population, but definitely the elderly.
Okay, what is elderly? Because sometimes I feel pretty old.
I know, me too. I'm getting there. I don't know. I mean, it's really hard to say what that cutoff range is.
Okay.
I mean, I think that when you start having these comorbidities, you're taking blood pressure medication. Maybe that's something that you think about. Is it harder to recover from your illnesses?
So
have you been hospitalized?
That's not always age specific.
Right.
That can be an individual's underlying conditions. Okay.
This is true.
Okay.
So I think that it's hard to really say which way to go, but I mean, you want to take the lesser of the approach and
okay. So I personally do the flu and I do the COVID because I just want to avoid the complications of COVID. But I didn't do pneumonia, and I felt like I could clear my lungs, which I don't have any other underlying conditions that would prevent me from doing so. But at a certain point in my life, I may want to start thinking about the pneumonia vaccine.
And I think if you've been hospitalized before, that's a trigger.
And it's all about reducing the symptoms. It's not necessarily avoiding it altogether.
That's right. You're still going to get flu. You're still going to get pneumonia. You're still going to get COVID.
Right.
It's just not as bad.
Got it. Okay. Well, let's wrap up.
Sure.
Is there anything you can tell us about how to keep our lungs healthy in the winter months that we haven't already covered?
I think just exercise, and whether that is just making laps around your kitchen because it's cold outside. You don't want to go outside. Right. But I think just general exercise, keeping your lungs nice and open, not laying around, movement.
Okay.
Getting up off the couch, walking around as much as possible.
Okay.
Because it's cold outside. You don't want to go outside. So
I just want to come back. It just occurred to me on the topic of vaccines. I said, let's divide it between the healthy and the people that have underlying conditions. What I heard you say is the more underlying conditions you have, the more important it is to reduce the effects of these common diseases that happen during the wintertime, flu, pneumonia, et cetera.
Right.
And so it takes on added importance based upon your own vulnerability, which is based upon whatever underlying, if you have asthma or if you have COPD, you definitely don't want to get something that'll put strain on your lungs.
Right. And you don't want to be in a hospital.
Okay.
I mean, we would love to see you, but not in that circumstance.
Right, exactly.
But yes, you're right.
This has been fascinating.
Well,
this has truly been fascinating. Thank you so much for joining us. And thank you all for joining us for another episode of Cup of Joe. I hope you got a little something out of it. I certainly did. And we look forward to seeing you at the next episode.